the remainder of chapter 7. And let's take a peek. Okay. Can everybody see my screen? I hope, okay, I see one person. Yes, okay, perfect. Thank you. Thank you, thank you. All right, good. Okay, so we were finishing up talking about intramembranous ossification, and and endochondral ossification. And then after we completed that, we talked about bone growth, the interstitial bone growth, lengthwise bone growth, and now we're going to talk about the appositional bone growth. So remember, interstitial, okay, that is when the bone will lengthen, and that happens in our long bones at those epiphyseal, well, at all the bones, I should say, but specifically when we're talking about the long bones, at the epiphyseal growth plate there. And so now we're going to talk about appositional bone growth as the bone thickens. Okay, so again, we're going to see this type of growth. Remember the periosteum, that's the covering to our bone there. And so we have that intercellular layer. So we're going to see, all right, the periosteum deposit. But if you look at the picture here, it's a great picture. Okay, you can see as the periosteum is growing bone on the periphery here, we're going to have the osteoclast on the inside resorb, all right, the old bone tissue. So as the outside, it keeps getting pushed out further and further, the periphery as the periosteum is laying down, all right, bone, then the osteoclasts and the medullary cavity here just kind of clear the way and just make it bigger and bigger. So you can see, right, quite a difference here between the medullary cavity in an infant as it progresses out to an adult. Okay, so that's appositional bone growth. Keep that in mind, all right? We do have two cell layers at work here. You got the inner cell layer at the periosteum, and then you have the endosteum, which is made up of those cells there, and the osteoclasts in the endosteum are going to resorb the bone on the internal portion here of the medullary cavity. So you may have heard of this condition, achondroplastic dwarfism. Okay, so this is where, right, folks have an issue, right, with this. Well, one, it's a genetic trait, okay, but what we'll see is we are going to see an issue in the growth plate. Specifically, the chondrocytes are going to be at fault here. And so as a result, right, we see that at that growth plate there, the chondrocytes are not going to undergo in those zones 2 and 3, the prolific and the hypertrophic zones there. We don't see them grow, we don't see them enlarge, and so we get inadequate, all right, ossification process of those bones. So the long bones, all right, you will see do not continue to grow, whereas other bones will still continue to grow. And as a result, you'll see folks, the long bones, which are going to be in your extremities, they'll have a short stature, short arms, short legs, but you'll see in comparison, their head may appear large because the bones there continue to grow. Because a lot of those bones in the head aren't going to undergo endochondral ossification. They're going to undergo intramembranous ossification. So what we'll see then is that irregular formation of the bone as it's converted over from the cartilage into our actual bone tissue here. Okay. So we learned how to make bone. We learned how to make cartilage, right? We just talked about how we can make bone and then tear down the bone. But what about bone remodeling? Right? As you know, the bones in a child are much smaller than the bones are in an adult. So remodeling is going to be an ongoing process. It's going to carry through a lot of it, or a good amount of it, I should say, occurs, all right, in childhood and adolescence, right? And it continues on to adulthood, but when you pretty much stop growing and if your weight doesn't fluctuate all that much, okay, you won't see significant bone remodeling, okay, in older people, right? It really just depends on what your skeleton is undergoing at the time. So when we talk about bone remodeling, okay, we're going to be talking about what occurs in the periosteum, which we kind of saw with that the appositional growth there. And then we'll see what happens at the end osteal surfaces. So on average, all right, about 20% of your skeleton is going to be replaced. That doesn't mean in 5 years that 100% of your skeleton gets replaced. In some places of the skeleton, you will not see. For example, the diaphysis, the shaft of the femur, right? That could take a whole lifetime and not even be done in a whole lifetime where it gets turned over. But in the distal part of the femur, okay, that'd be down by your knee, that gets overturned quite frequently, right? 4 to 6 months. And again, a lot of it is activity dependent. Activity dependent. So what we're going to see then is we're going to see some sort of symphony, okay, this nice concert between the bones, the cells that make bone and the cells that resorb bone. Okay, so we got to have it in a nice coordinated event so we're not undergoing abnormal bone remodeling. So this process is heavily influenced by hormones and general mechanical stress. So let's start off with the easier one to talk about, the mechanical stress. Weight bearing and exercise. So this is going to happen in people whether they're exercising or not. It'll vary depending on your activities, okay? But this occurs, it's a normal process, right? Especially if you're a person that stands a lot, you're upright, your bones are going to be remodeling themselves. So of course, right, it starts off with our osteocytes. They're monitoring any of the stresses on the bone matrix. And if there is an increase in stress, right, then we need to trigger new bone growth. So the osteocytes will then trigger osteoblasts to produce more bone matrix, the organic bone matrix, the osteoid. And then, of course, you know what happens, okay? Calcium infiltrates, or the hydroxyapatite, right, will be, you get your calcium and phosphate crystals that will precipitate out into the osteoid and harden the bone. And so as a result of that, we get increased bone mass, which is good, okay? Because now, right, you can see, especially depending on what your activities are, whether you're a runner or somebody that's on their feet quite a bit, or you've suddenly gained or even gradually gained a lot of weights from either being sedentary or from exercising, whatever, okay? You'll see an increase of bone mass because the weight-bearing activities that you have undergone have also increased. So what will happen to decrease that bone mass, right? Being in a coma for a year, you're going to be lying in bed, right? Going up to space, not having any type of mechanical stress on the skeleton will decrease the bone mass. So as you get older, you can see why it's important to stay active, okay? Especially in older folks, because it helps maintain the bone density. All right, so the other part or influencer of our bone remodeling is going to be our hormones. Right, so we talked a little bit about hormones. Okay, they're chemical messengers. They're these specialized molecules that will go around and trigger cells to do stuff. And so these hormones, these chemicals travel in our bloodstream. And so we have certain cells that make these hormones and secrete them. Then we have certain cells, which we call target cells, that have specific cellular receptors on them. So when that hormone comes along, it binds to that cellular receptor and it causes the cell to do something. If it makes proteins, it'll make proteins. Okay, if it's supposed to secrete something, it has to do something. Okay, so we're going to talk about the hormones that are going to influence, all right, the rates of your chondrocytes, your osteoblasts, and your osteoclasts. All right, so we're going to talk about what's going on, because you always hear about kids when they're going through their growth spurt. Well, now we're going to learn a little bit about, what it is, what influences this growth spurt. So what better hormone to start off with than growth hormone, also known as somatotropin. Okay, This hormone is made in the anterior pituitary gland. You first heard me talk about the pituitary gland when we were talking about the sphenoid bone in the axial skeleton, specifically in the skull. The sphenoid bone has this structure called the sella turcica, the Turkish saddle. And that's where the pituitary gland sits, right up there in the middle of your skull. And so what it does is it is going to produce growth hormone. That growth hormone will circulate around. And as a result of that growth hormone going to the liver, it's going to stimulate the liver to produce another hormone that we call insulin-like growth factor, or IGF. Okay. And so both of these hormones are going to influence the epiphyseal plate, and it's going to stimulate the whole growth process of that cartilage in the epiphyseal plate, which we already talked about. So it's kind of cool. One hormone gets released, stimulates the release of a second hormone, and they both go to work on the cartilage in the epiphyseal plate. So you probably thought that thyroid hormone was that hormone that helps to regulate your metabolism. Well, there's lots of factors to the metabolism, right? But one of which the thyroid hormone is going to influence, it's going to influence, again, growth at the epiphyseal plates. Okay, so we know that the thyroid gland, we know where that's located, right there in the anterior portion of your throat and your neck. And so what it does is it is going to, you probably don't know what this term means, right? Basal, okay, influences the basal metabolic rate. It influences the basic metabolic rate of bone cells, meaning their normal metabolic rates of things that they do. Like when you're sleeping, for example, your body still has to do certain activities to keep you alive. Okay, cells are going to be still making things that they make depending on what their function is. Okay, so the thyroid hormone can influence that basal metabolic rate, and it can increase, okay, things, and it can also decrease things if the thyroid hormone is absent. So thyroid hormone is just going to increase the metabolic rate or the basal metabolic rate of these bone cells. And we know what bone cells do. They make bone, okay, except for the osteoclasts. So we'll see, all right, that the thyroid hormone is going to affect the activity there at the epiphyseal plate. And so without thyroid hormone or significantly decreased secretion and production of thyroid hormone will not significantly, but it can affect your growth rate. Okay, of course, our sex hormones, they play a huge role. That's why when you go into puberty, okay, up until that point, your body wasn't producing, all right, estrogen for females and testosterone for males. What happens is you hit puberty, bam, okay, your cells start to produce estrogen and testosterone. And at this point, that will drastically increase your bone growth, because how it works is it stimulates the cartilage growth at the epiphyseal plate, and it speeds up the conversion of cartilage into bone. So that's especially, you'll notice when you were entered into puberty, you may have gotten a little bit taller or a little bit thicker. All right, so as a result, over time, as your estrogen and testosterone kind of taper off, now growth hormone tapers off much earlier than estrogen and testosterone, but you reach a certain age and eventually many of your hormones will start to taper off in production. Okay, but conversely, when you hit puberty, you start secreting massive amounts of both of these hormones, which will stimulate the growth plates there. Glucocorticoids. All right, these folks are the ones that folks like to utilize, all right, when they're in a situation of lots of inflammation. So glucocorticoids are made by the adrenal cortex, which is the outer portion or layer of your adrenal gland or suprarenal gland. Okay, so what will happen is they play several different roles, one of which you'll learn in chapter 17. It helps to regulate your blood glucose level. In fact, they help to increase your blood glucose level. So you release a decent amount of glucocorticoids when your blood sugar level is low. All right, but what can happen is, this is a group of hormones that you'll see on folks. If you're looking at an x-ray, and you can tell, for the most part, by looking at an x-ray how the bone density is. Is there too much? Is there too little? Most of the time it's going to be too little. And folks that have been on glucocorticoids for a long period of time, steroid treatment, long period of time, will see a significant increased amount of bone loss. Now, you don't want to mess around with this stuff, right, with little kids. That's why I'm hesitant, and I'm reluctant, unless absolutely necessary, to give kids, all right, steroids for asthma treatments, right? It's one of those, let me just say long-term chronic asthma treatments. I should be specific on that, okay? If it's where they're just at a time of the year, for like a month in October, where their allergies are really bad and they need it, that's fine. But I'm saying months to years, right? You want to back off on that, because overall, all right, what we'll see is a decrease in growth of the cartilage and bone formation there in the epiphyseal growth plate, but overall it can thin out the bone density, and that can lead you to some issues with stress fractures and all sorts of complications, and so you don't want to really mess with that. All right, serotonin. Now we'll talk about serotonin briefly a little bit when we get into the nervous system, but it's a neurotransmitter, right? Especially for folks that suffer from depression, okay? And if one of the causative agents for that depression is a decrease in serotonin, it's a neurotransmitter. That's why we have drugs that are called like SSRIs, selective serotonin reuptake inhibitors, which we'll talk about later on, right? But it helps, right, to stave off depression. But yes, it's a neurotransmitter, but it's also a hormone. And what we've seen is in our bones, you'll have these specific serotonin receptors there. And so, of course, if folks are taking, again, I'm not trying to poo-poo a pharmacology or drugs, okay, but if you have young kids, I'm not saying like a 7-year-old, I'm saying like a young teenager that's taking, all right, these SSRIs, right, it can increase the level of serotonin. And what will happen is those osteoprogenitor cells, right, are unable to convert into osteoblasts to make bone. And so that's why we have to be careful, right, with how much is given if you're trying to treat somebody with depression. All right. Okay, so you can see at the top of the slide, we're going to now talk about regulating blood calcium levels. Well, I think, we really haven't given calcium its just due. And so I hope that after we talk about it a little bit here, that you'll come to appreciate it as much as I do. All right, you need calcium for several different chemical processes throughout your body. But in this semester, we're going to talk about some of these here. Right, when we get into chapter 10, which is coming up soon, we're going to talk about how we need it for muscles to contract. Well, that's kind of important, right? Because if we're not having muscles contracting, then we're really not able to move. And especially if we're dealing with smooth muscle, God forbid, cardiac muscle, right? So calcium is kind of important for that. So we need that, right? We're also going to need it, all right, for the release of neurotransmitters, okay, through the process of exocytosis. So we need it for a functional nervous system. That's important, okay? In 211, you'll talk about its importance on the heart. We'll touch on it a little bit this semester, okay? But again, all right, muscle cells will need calcium, okay, to stimulate and to regulate contractions. And then, of course, blood clotting, okay? Calcium is important for the clotting cascade, which is a series of chemical reactions through a bunch of enzymes, right, that allow for our blood to clot. Blood clotting is important, especially if you are hemorrhaging or bleeding, okay? Blood clotting is bad when we're talking about clots inside the arteries and whatnot. So the two hormones that play a huge role in regulation of blood calcium levels are going to be calcitriol. We've heard that before. That's the fancy name for vitamin D, and parathyroid hormone. So just a quick review about how vitamin D goes from the inactive state to the active state. Your keratinocytes in your skin are going to synthesize, all right, the vitamin D3 cholecalciferol. And it's going to release it into the blood. And so it'll circulate all throughout your body. And at one point, it's going to wind up in the liver. And so the liver then converts it into calcidiol. Once that happens, it gets released back into the blood. Now it's calcidiol, and it circulates around until it finds its way into the kidneys. All right, and here's where it's important. The kidneys convert it into calcitriol. Now, calcitriol is important because it helps to absorb calcium from the small intestine. All right, so that's good. But also, okay, parathyroid hormone, PTH, we're going to talk about that here in a second, can also influence the rate of calcitriol formation. And so if parathyroid hormone is being released, okay, it will increase the rate of this formation so we can absorb more calcium. So that's great. So basically, parathyroid hormone is synergistic, works together with calcitriol. So it enhances its formation. So here you can go. That's funny. I always laugh at this. You know, you can get a good supply of vitamin D through the milk. And that's true. You can, a decent amount. It's not bad, but it's added to the milk. Why not get it the old-fashioned way or the more natural way and get it from the sun? Get outside, right? It's great for you. Okay, you can get it from your diet, and you can, so have at it. Drink some milk, okay? Eat some veggies, all sorts of good stuff. Okay, but it's really this organ here. That's the big guy here. Okay, the kidney is going to convert it into calcitriol, and then we'll have that active form. So parathyroid hormone is made by the parathyroid glands that sit on the back of your thyroid gland. All right, so they have one role that we already talked about. Okay, will increase the amount of calcitriol that is going to be produced by the kidneys. That's huge. All right, so now when we're talking about parathyroid hormone and calcitriol, what's the reason why, you know, we're producing this? Our blood calcium levels have decreased. Okay, so we need to, therefore, that's our stimulus. Okay, our stimulus is reduced blood calcium levels. And so when the cells in your parathyroid glands, all right, are going to be stimulated, and you're going to talk about this in chapter 17 next semester, right? But you have a hormone that's released, okay, by your pituitary gland that's going to stimulate the secretion and release of the parathyroid gland, of parathyroid hormone from the parathyroid glands. And that's as a result of the reduced blood calcium levels. So our goal is to increase our blood calcium levels. So we're going to involve 3 organs. Okay, so bone. Remember, one of the functions of bone was a storage site for minerals and energy reserves. Code for calcium and phosphate. So what will happen is, right, we'll see the osteoclasts in the bones start to break down our bone matrix there. They'll liquefy, right, the osteoid, releasing the calcium and phosphate salts, right, out of there. And so it'll free up those ions to return to your blood. So both PTH and calcitriol will work what we call synergistically. They work together, and they'll increase the release of calcium from the bone. Meanwhile, right, in the kidneys, we're going to see your kidneys excrete less calcium in the urine. And therefore, it's going to increase the resorption of calcium. It's going to keep it in the blood. And then the small intestine, the calcitriol, obviously we talked about this before, is going to increase the absorption of calcium. So all that goes on when you have low blood calcium levels. And so here we're seeing, and this is, you'll see the same picture in 211. Okay, the stimulus, low blood calcium, is going to be, is the stimulus. Okay, we have the receptors here. They're going to monitor that. and they're going to release parathyroid hormone into your bloodstream. And so PTH is going to go to the small intestine, or excuse me, it's going to go to the kidneys, stimulate an increased amount of calcitriol being produced. Okay, both of them together will work on bone to help break down the bone matrix so we can get more calcium and phosphate released into the blood. And then we'll also see parathyroid hormone and calcitriol tell the kidneys, all right, don't get rid of any more calcium, hold on to it. All right, we're going to resorb as much of that calcium back into our blood. And then vitamin D3, our calcitriol, is going to increase calcium from absorption from the small intestine. And that will swing our blood calcium levels back into our homeostatic range. Kind of a cool system. All right, rickets. Rickets. I briefly mentioned this, I think, to your section before about rickets, but specifically, rickets is a deficiency disease of vitamin D. We just talked about what vitamin D does. And so if we have a decrease in vitamin D, and that means what we'll see is a decrease in calcium. And if we cannot calcify our bones will be more soft. Remember, we have to have that proper ratio of organic bone matrix to inorganic bone matrix. And so if one swings widely in one direction out of control, then that's going to affect the integrity of our bone. Well, in this case, we don't have enough calcium, okay, to harden the bone. So our bone is going to be much more softer. Now, it's not going to be soft like pudding or anything like that. But what you'll see is, especially on the weight-bearing bone, long bones of the lower extremity, you'll get people that are bow-legged. So their legs will stick out like that. All right, so what we'll see is, unfortunately, depending on how bad the deficiency is, okay, you will see some disturbances in the bone growth, right? It can, if it's bad enough, lead to hypocalcemia, decreased blood calcium levels. And if that is pretty significant, then I told you one of the things that we can see in its function is the function of nerves and muscles. So what we'll see is some tetany, cramps and twitches. We really don't see this too much in the United States. If you do, you should be suspecting malnutrition, right? They're not getting enough, or they're just not going outside enough. They're not getting enough vitamin D. Okay, they could be pale as all get out. And we're seeing it a little bit more nowadays than we had before, because especially now with COVID, less people are going outside, right? And they were staying inside, but people, playing video games, watching more TV. We're not as active outside as we used to be. You're more likely to see it in a developing nation and less in the US. All right, calcitonin, another hormone. You'll talk more about this, but we should talk about it now. All right, calcitonin is going to also help regulate your blood calcium levels. Okay, in this situation, what we'll see is this hormone gets released when you have high blood calcium levels or hypercalcemia. The thyroid gland releases, calcitonin. And so you'll see it, when your blood blood calcium levels have increased, and that can happen quite often when folks are exercising. Okay, because the bone growth will be triggered and you'll have increased calcium levels occurring. So what calcitonin is going to do, it's going to trigger the kidneys to get rid of calcium. So how does it get rid of it? Sticks it in the urine. That helps to reduce the blood calcium levels. But we'll also see it'll take that calcium and it'll stick that calcium, into bone. How do we do that? Well, we inhibit the osteoclasts. I should be crossing that out. And so if the osteoclasts are inhibited, that means we get less bone resorption and more bone formation. So think of it like putting calcium into the bone. That's how I remember calcitonin. Okay, let's finish up this chapter and talk about aging on our bone, and then we'll talk about a bone fracture, and then we'll be done with the bones. Okay, so when we talk about aging effects, we probably know some people that have had some issues with the integrity of their bone. So what we'll see when we're talking about aging in bone, we're going to see, remember, things slow down, things get decreased, so this is no different, right? We're going to see a decrease in the tensile strength of bone. That's basically how much flexibility a bone has. We talk about tensile strength. How much bend can we put in a bone before it snaps? So obviously, if we decrease the tensile strength, we can't bend the bone a lot. And a lot of that time is because those osteoblasts have a hard time making the osteoid, specifically collagen. So we get a reduction in the protein synthesis by those osteoblasts, but we still have the inorganic material en masse. It's all over the place. Okay, so what we'll see is that proportion swings out of bounds, right? And so we get a decrease in the protein synthesis, makes the bone less bendable. So then we see more brittle and bones that are more capable of breaking. Right. We'll also see a decrease in calcium and phosphate, magnesium, all these other minerals. Okay, because a lot of the times people's diets taper off. Your body's just not as good as absorbing certain materials in the digestive tract. So there's going to be less calcium and other ingredients for our bone. So the bones become what we call osteopenic. They become thinner and they become weaker. Okay. And that's because we're not able to get the bones to ossify very well. So osteopenia, right? We see this at all different age groups, all right? But more so you're going to see it in the latter ages. And it varies depending on how severe it is. So as you get older, your osteoblast activity decreases, so you're producing less osteoid, right? But we'll see the osteoclasts, for whatever reason, they don't slow down. So they keep right on working. And so we have, all right, an improper proportion of bone formation and bone resorption. We're starting to see less formation, and bone resorption continues on at the previous levels. So in comparison, it has increased a little bit by comparing it to the old reduced level there. Right? So we'll see this more often in women than we will in men. Part of that is also believed to be due to hormones. So here's another condition that we'll see in women more than men, and that's osteoporosis. This is when we see a significant amount of bone mass. And again, we'll see it in the older population, but women will experience osteoporosis much more than males do. And part of it, again, we see it, we blame it on hormones, okay? I mean, obviously vitamin D, that's why it's always encouraged to take supplements the older that you get, right? But you can see vitamin D, growth hormone, estrogen, and testosterone, all of those decrease with age. And so as they taper off, okay, your bone production will also taper off. So what is osteoporosis? Okay, weakened bones that in some cases can fracture somewhat easily. Okay, we'll call it that type of fracture is called a pathologic fracture. Right? And so we'll see it more so in the older population, more so in women, especially after menopause, again, because that drops the amount of hormones that are being produced in females, that drops significantly. If you're white, if you smoke, if it runs in your family, sedentary lifestyle, all of those things play a big role. All right, sedentary lifestyle plays a larger role than most people think. right? So what we're usually worried about is these fractures. How many times have you heard somebody fell and broke their hip? Well, did they fall because their hip broke, or did they fall and then when they fell down on the ground, their hip broke? Okay, who knows? Usually you get that from the history there. But point being is we want to avoid that. We want to avoid these issues. So, of course, we try to do behavior modification. Tell folks, listen, you need to be more active. Easier said than done in some cases, but most of the time I just tell people walk. Just go and walk, okay? Obviously, eating a healthy diet. And when I say a healthy diet, you know, you've decreased your processed foods and you're maintaining, all right, a healthy food ratio there. And then, of course, what we'll do is if it's bad enough, there's always drugs, okay? Drugs will always be part of the recommendation. Okay, so bone fracture repair, last part here, I think. All right, so a couple of different definitions here. What is a fracture? It's a broken bone. And there's different types. Some of you may have heard of some of these. Stress fracture, okay, this comes from repetitive trauma, right? When you increase your physical activity, all right, from running or playing volleyball, compressive sports, you see it quite a bit in folks that run quite often, okay? So stress fracture. Talk to you about the pathological fracture. That's usually as a result of some sort of disease. This is the ideal type of fracture that I would like to have as a simple fracture, broken bone that has not penetrated the skin. I like that. Compound bone, big problem. Okay, that is where, all right, the bone has pierced the skin. Okay, so then you have to worry about a whole slew of other things, all right, other than just resetting the bone. So figure 7.16, you can look through and look at all these different types of fractures, okay, just to kind of get an idea. All right, at one point, I used to know all the names. I know most of them, but I don't remember all of them. All right, so all right, let's figure out how a bone, after it's fractured, heals itself. Now, when we're talking about the heal time for fracture, I had a fracture in my tibia when I was in 4th grade, and I had to wear a cast for at least 2 months, which I was surprised, but I had to wear one for 4 weeks that went up to my hip, and then the other one went up to my knee. So it varies. So simple fractures usually will take the shorter period of time, 2 to 3 months. Compound, much longer, and it also depends on how much displacement that had occurred. If it's really bad, then that's when they start to get the screws out and the pins and all that. All right, so there's 4 steps. The first step is you broke the bone, you've damaged blood vessels, and now you're going to get blood accumulating in a certain area. And so we call that blood hematoma, which is just that clotted blood in the area of the fracture. So here you can see in our very first picture right here, there is our fracture. We've broken the bone, damaged the blood vessels, and so blood has now filled this area here, okay? And that is our hematoma. So you get some swelling that occurs, not abnormal. All right, so step 2, we need to make a mold. We've got to stabilize this area here. So this is where we get our soft callus, or what we call the Fibrocartilaginous callus formation here. So as that hematoma is, you know, that blood there, now we're releasing cells into the area there. So what are we going to get there? Fibroblasts. What do fibroblasts do? They produce the collagen. Remember what I've said with fibroblasts before in skin wounds, right? They make the scar tissue. So collagen is basically scar tissue. So the fibroblasts are going to lay down this collagen, and then the chondroblasts come in and they start to make they make cartilage. And so we're going to get this mixture here. We call that the procallus. And it's just this connective tissue model or template that we're going to start to in the healing process as we're going to start to rebuild everything. So that's what's filled this area here. It's a bunch of cartilage and collagen fibers, right? That's going to be in the cartilaginous matrix, and we're just going to start to, secure everything, all right, stop the bleeding and start the repair process. All right, so that brings us to step 3. This is when we get our bony callus. Okay, so we have our soft callus, all right? And so what we're going to see now is we're going to convert that cartilage to bone. So the osteoblasts come in and they start to build up the trabeculae there. And as they're doing that, they're going to start to put their bone tissue over the cartilage. And so that's going to release or get rid of that kind of scab-like structure and convert it from a soft callus into what we call a hard or bony callus. And so here you can see, okay, now we've resorbed and gotten rid of all the cartilage, and then we're putting in our primary bone here. Now, primary bone is that woven bone. It's not very good. Okay, you can see we've got all this trabeculae in here. Okay, we want compact bone in the periphery. Okay, so this is that primary woven bone as we talked about before. So we want to make it better. So what are we going to see now? What we've talked about the previous slides is now we're going to remodel that primary bone and we're going to turn it into that secondary bone, that lamellar bone. And so we're just going to replace that old trabecular bone with compact bone in the right spots and then spongy bone in the right spots. So the osteoclast will get rid of the old bone material and then the osteoblast will replace that with our new bone material. And so that we'll see here. And there you go. And then over time, okay, you can see there's a little bump here. Over time, some of that will go down, okay, as the bone starts to remodel itself. All right. Well, that concludes that chapter. It's kind of bittersweet, wouldn't you say? All right, I want to get into chapter 9 here. We're going to start it off. And then we'll take a break here. Where are you? I'm missing you. Where are you? Okay. All right, chapter 9, one of my favorites, articulations. Love articulations. Joints. All right. So this chapter is it's a little bit easier of a chapter than some of the previous ones. So it's a nice chapter to kind of finish up all the material that's going to be on your second lecture test. So a joint, you hear me refer to it many times as an articulation, okay, is going to be a space, an area, right, in which bones are going to contact one another, or cartilage, because we can have our cartilaginous joints, which can be an articulation between a bone and cartilage, and even our bones and our teeth, one of our digestive organs. Bet you never thought your teeth were a digestive organ. Okay, so what we're going to see when we're talking about joints is we're going to classify them by both structure and function. Now look at those words, structure, function. You heard me talk about those words before. And in fact, you heard me talk about them way back in chapter 1 when we were learning the definition of anatomy and physiology. So I can replace structure and function with anatomy and physiology. So we can say we classify our joints by their anatomy and by their physiology. So structure and function. So let's start off with the classification of the joints structurally. Our fibrous joint, cartilaginous joint, and synovial joint. Those are the 3 types of joints. So when we talk about a fibrous joint, we're going to hold the bones together with a connective tissue. It's going to be a nice, strong, dense connective tissue. A cartilaginous joint is going to be a bone and cartilage. It's going to be bones that are held together by cartilage. And then finally, our synovial joint, I love these guys. All right, they're going to have a fluid-filled joint cavity, and it's held together by these ligaments. So for classification for joints functionally, we have these 3 functional classes: synarthroses, ampharthroses, and diarthroses. All right, the first one, the synarthroses are immobile. They don't move. So these can either be the fibrous joints that we just talked about, that's the one where the bones are connected by dense connective tissue, or the bones are connected by cartilage. So synarthroses can be either of those, fibrous or cartilaginous. Ampharthroses are just slightly mobile, and they're the same, meaning as synarthroses, they can either be fibrous or cartilaginous. Then my favorite is the diarthroses. These are the freely mobile joints. They're all over the place, like your shoulder, perfect example, moves all over the place. And all diarthroses are synovial. So it's a great true-false question. True-false. Diarthroses are synovial, or all diarthroses are synovial. And you'd say true. All right. So I want to talk to you about this concept called range of motion. I talk to my patients all the time about range of motion. And if you've ever gotten an email from me that I send from my iPhone, it says motion is life, never stop moving. Okay, so range of motion is important when we're talking about how much movement occurs at certain joints. And so it's very extensive. It goes from no movement to a lot of movement, basically. Right? So how much movement really depends on the anatomy of the joint. So therefore, the structure of the joint determines its mobility. And so that now brings in a second concept, which is stability. That just clicked. Ah, you should have said popped, because that's what we do. No, there's a lot more than what we do. So when we're talking about the range of motion of joints, there's two things you have to take into consideration: how much movement is in the joint and how stable the joint is. So this brings us to a very important concept here. Right, we learned about inverse relationships way back when. In chapter 2, for example, we learned about the inverse relationship between hydrogen ion or proton content in a solution and the pH scale. We learned that if you have a higher amount of hydrogen ions in the solution, you have a low pH. And if you have a low concentration of protons in a solution, then you have a high pH. This has to do with acids and bases, in case you don't remember. So as one goes up, the other one down. That's an inverse relationship. So here, when we talk about mobility and stability, the more mobile a joint is, the less stable it is, and vice versa. The more stable a joint is, the less mobile. So the example there is the skull sutures, coronal suture, sagittal suture, right? Those are joints, all right, that they are fibrous joints. Okay, they're connected by dense connective tissue, right? They don't move a lot. You can push on yours right now and tell me if you feel any movement there. So they're very stable. I don't know. I've never met anybody that's ever had a dislocated frontal bone. But I know plenty of people that have had dislocated glenohumeral joints. That's your shoulder. So your shoulder joint is quite mobile. So the more mobile it is, the less stable it is, and the more prone it is for some sort of dislocation. Okay, so you have this nice little picture here showing mobility and stability. The less mobile you are, the more stable you are. And the more mobile you are, the less stable you are. Okay, so let's talk about our fibrous joints. I went there, I brought it up, so I need to talk about the fibrous joints. All right, we just talked about one, all right, our coronal and sagittal suture joints, right? So this is the joint in which the bones are connected by a dense connective tissue, specifically dense regular connective tissue, so it's very, very strong. You have to know this, there is no joint cavity. So these joints have very minimal amount of mobility, if at all any. Okay, so they're either immobile or barely mobile or slightly mobile. So there's three types: the gomphoses, the sutures, and the syndesmoses. I love the gomphoses. And when I show you a picture of the gomphoses, there it is. That's your tooth. Your tooth is a gomphosis, peg in a socket. And so we'll see, right, our teeth, as they're inserted into our maxilla and our mandible, right, they're held into place. If you look down here, and you go into this a little bit more when you get into digestion in chapter 26, okay, you can see here's your tooth. It's a nice peg. We stick it down into the socket in the jaw, and then it's held into place, all right, by our ligaments here, the periodontal membranes. They're tiny ligaments, and they hold, I mean, they really rock it. They hold that thing in there. Your teeth are relatively immobile, right? Although I feel like mine are sliding all over the place the older I get. But what we see is, right, these joints are held into place by fibrous tissue, right, those periodontal membranes. And so physiologically or functionally, they're going to be a synarthrosis, so there's very little movement there. Our suture joints, okay, we just talked about that. I won't go into much detail. Again, another fibrous joint. Bones are held together, all right, through the dense connective tissue there. Also another synarthrosis, not a lot of movement there, right? And then over time, when these joints eventually ossify, then they're no longer a joint because it's now an ossified area there, so it's considered to be all one bone. All right, we saw this joint before when we were talking about the upper extremity on Tuesday. We were talking about pronation and supination. All right, so we'll see in the syndesmoses, you have this intraosseous membrane in between the radius and the ulna. And that interosseous membrane acts at, well, it pushes the bones away from one another. It's like two guys, they're going to get into a fight, and a third person steps in between and puts their hands up to push both the people away from each other that are going to get into the fight. That's what the interosseous membrane does. It pushes both the radius and the ulna away from each other. But the nice thing about it is that it acts as a pivot point. Okay, so for that supination and pronation. So when you go into pronation, it also helps to keep the radius pivoting on top of the ulna here. So therefore, because there's a decent amount of motion there, we'll see an ampharthrosis. Did I say a decent amount? Where am I going? There we go. All right. You're not going to see a decent amount of motion in between the radius and the ulna, but you will see a decent amount of movement here at the radial head. I'm throwing two different concepts at you there. I apologize for that. My bad. Okay, so the next type of joint that we're going to talk about is the cartilaginous joints. These are the joints that the bones are held together by cartilage. So there's two types of cartilage when we're talking about the skeletal system: our hyaline cartilage and our fibrocartilage. Again, there's no joint cavity. And so these types of joints will be virtually not immobile, or there'll be a small amount of mobility there. So there's two types: Syncrondroses and a symphyses. All right. So the Syncrondroses, we saw this when we were talking about our growth plates. And also we'll see it at the area where the costal cartilage, right, attaches onto your rib. That is a Syncrondrosis. A symphysis is, and we've seen this a couple spots when we're talking about the fibrocartilage, right? We'll see that in the pubic symphysis right up front here. We got a nice little disc there. And then we actually have our intervertebral discs in between our vertebrae. So they will allow a slight amount of mobility going on. And so we classify them as amphithroses. Which, since we're talking about the costal ribs, I should bring up costochondritis for some folks that have ever suffered from this. Usually it's in folks a little bit older, okay? At least that I've seen it. I've never seen it in young people, someone in their adolescence or in their childhood. But anyways, what happens is, all right, patient will come in complaining of chest pain. And God forbid if it's anywhere near the sternum. In most cases, it usually is. And if it's on the left side, people usually start to think that it's some sort of heart attack, okay? So careful on that one. But pretty much this is an idiopathic etiology. What does that mean? We don't know what causes it. It's assumed that it's either a trauma or some sort of infection. That's why it responds very well to anti-inflammatory non-steroidal drugs. But steroids also work great. But basically what happens is, right, you see swelling, inflammation at those costochondral joints there. All right, the last type of joint I want to talk about is our synovial joints. These are the joints that have, all right, a capsule. The bones are where they articulate with one another, surrounded by a capsule, and that capsule, there's a joint space there that's filled with fluid. So this is what we're going to see. Most of the joints in our body are synovial joints. Remember what I said before, right? All synovial joints are diarthroses, freely movable. So if you look below, you can see a couple of the features here. So one, we're going to have a capsule, and that capsule surrounds the joint cavity. In that joint cavity, we're going to have synovial fluid. Also, we'll see articular cartilage. And then part of our joint, our articular capsule, will have ligaments. We'll find some nerves in there and some blood vessels. So here's a nice picture of a synovial joint. I'll zoom in a little bit so you get a little bit of a better picture. Okay, so here is, all right, the two bones articulating with one another, surrounded by a capsule. All right, the outer portion of the capsule is going to be not a dense connective tissue. So it's that we call that the fibrous layer. And then you've got a smaller layer on the inside. I'll go through more of a specific description of these, right? Which is the synovial membrane that produces the synovial fluid here. And then you'll also see our articular cartilage, specifically where the two bones articulate with one another. And then we'll have on the outside of our capsule some ligaments. Doesn't necessarily cover the whole capsule, but there'll be some ligaments involved. All right, so let's start off by describing our articular capsule. Two layers capsule. The outer layer is going to be that dense connective tissue, prevents the joint from coming apart. The inner layer is going to be made up of a single layer of areolar connective tissue, that loose connective tissue. And it produces the synovial fluid. But you'll also notice, I'm going to go back here to this picture. If you also notice here, where you see the synovial membrane, all right, it will not cover the articular cartilage. Think about it. Think about it. If it were to cover the articular cartilage's job is to decrease friction in the joint, also acts as a shock absorber. Well, you don't want that synovial membrane getting in between these two bones. Those bones will grind that synovial membrane to dust. So we don't see the synovial membrane on the articular cartilage. Okay, so where there's articular cartilage, you will not see the synovial membrane. All right, so speaking of articular cartilage, we've already discussed what type of cartilage it is. It is a hyaline cartilage, okay? Decreases the amount of friction that occurs in the joint and acts as a shock absorber. All right, this is an interesting fact. All right, we know, all right, that mature cartilage is avascular. So this type of cartilage is no different. It's avascular, but it does lack a perichondrium. Remember what the perichondrium is. We learned that out of there's three types of cartilage. hyaline cartilage, fibrocartilage, and elastic cartilage. Well, hyaline cartilage and elastic cartilage have a perichondrium. Fibrocartilage does not. This is one of the exceptions to the hyaline cartilage. So articular cartilage, make a note of this, articular cartilage, yes, it is hyaline cartilage, but it does not have a perichondrium. So in our joint cavity, that's that space, right, around those bones that are articulating with one another, we'll have our synovial fluid. I like synovial fluid. I just went and got the oil changed in my wife's car this afternoon. And they put the oil in the engine. And you know what oil does? Okay, it acts as a lubricant. And so oil's not like water, it's thicker than water. We can say that it's viscous. And so that oil in my engine, when those pistons are moving up and down, help to reduce friction. Well, the synovial fluid helps to reduce the friction in the joint cavity, especially on the articular cartilage there. So it lubricates the cartilage. Now we're making something that's slippery, even more slippery, helps to reduce friction. But also, this is important, it helps to bring in nourishment, and it helps to get rid of the wastes for the articular cartilage. Because remember, articular cartilage is avascular. So it's got to get nutrients somehow. It's got to get rid of waste somehow. It does it through diffusion. And so the synovial fluid allows for that. And it also acts as a shock absorber. How nice is that? Synovial fluid is the fluid that cares, and it keeps caring. It's a gift that keeps on giving. All right. So now we want to make our joint stronger. So what are we going to do? We're going to add some ligaments, some nice, beautiful, dense, regular connective tissue that's going to hold these bones together. And what they'll really do is, one, yes, they'll prevent the bones from being pulled apart, much like the fibrous layer of the capsule, but they actually will help to stabilize a joint. So the more ligaments you have around a joint, the more stability you'll have in that joint. But unfortunately, it can start to decrease some of the mobility. All right, so when we're talking about ligaments, we have extrinsic ligaments and intrinsic ligaments. Okay, the extrinsic, all right, are physically separate from the joint capsule. It's important to know that, because when we talk about certain ligaments to certain joints, we'll name some of these ligaments. And so those ligaments are the extrinsic ligaments. So they're not part of the joint capsule. The intrinsic ones are. All right, so they're going to be found, all right, within the joint capsule. So when we're looking at our picture here, all right, this fibrous layer here, that's going to be your intrinsic part of the, because it's part of the capsule, that'll be the intrinsic ligament. Then we have this separate ligament on the outside here. That'll be our extrinsic ligament. All right, and not to forget about sensory nerves and blood vessels. That will also be thrown in there. Now we will start talking about some of the different types of sensory nerves. Okay, yes, there's pain receptors in there, right, but also we're going to have what we call proprioceptors and mechanoreceptors, which are a type of proprioceptor. But we'll find these different type of receptors to help us with the proper movement that's occurring in the joints. And also, if a joint is being stretched too much, it will invoke certain reflexes. So these nerves are going to help to monitor the amount of movement and stretch that are going on, and if there's pain involved. Right, tendons, we already know what those are. And again, dense regular connective tissue, they attach the muscle to the bone. And guess what? They also help to stabilize joints. It's a phenomenon we really don't talk about too much, but muscles, and when I say muscles, I'm including tendons in that. It does help to stabilize a joint. Right? I saw it firsthand. A patient of mine was playing a football game, and he tore his ACL. The ACL, it's the anterior cruciate ligament. Real quick, it's one of the ligaments that helps to stabilize your knee. It basically prevents your knee from sliding forward, right? Your femur from sliding forward on top of the tibia, which is the bone in your shin. So this patient, if you looked at his legs are huge. You can't see me, but his legs were about as thick around as my midsection, my waist is. Big, just strong. and his glute muscles were strong, hamstring muscles, quadriceps, all these muscles were strong. Anyways, long story short is, so there's a test that you do to check, there are several actual tests that you do to check the ligament to see if it's torn. And so the trainer did all of these tests. He was negative for every single one of them. So it wasn't until he got an MRI where he found out that he had a torn ACL. But the reason why is because his muscles, he had a lot of muscles around his leg and his knee joint there that they stabilized the joint so well, all right, you couldn't tell if he had a torn ACL. All right, so that's tendons. So our bursa, our little cushioning, how do I want to say that? They're like bean bags, okay, except they're filled with synovial fluid. So the bursa sacs are going to be these little sacs that you're going to see found near joints, and their job is to I shouldn't say lubricate, but they reduce friction. So on the outside, they'll have a synovial covering that looks similar to like a tendon. On the inside, they'll have the synovial membrane there to produce the synovial fluid. So we'll find the bursa sacs all around, all right, your joints. So they'll be around ligaments, muscles, tendons, between the skin, all over the place. And so they're separate. They're not part of the joint, all right, itself. They are separate from the joint and joint cavity. But you can see here in this picture here of all the different bursa of the knee. Right, they're all, and this is even showing all the bursa, but they're all around areas where there's going to be a lot of friction. So where things are going to be rubbing past one another. Right, if you look here at the prepatellar bursa, right, it's right on top of your kneecap. Well, if you're running, you're constantly bending your knee, so that kneecap there, the patella, is going to rub against the tissues up here, causing friction. Well, problem solved. We throw the prepatellar bursa in there, now you don't have that problem anymore. So we'll see it quite a bit around a lot of the tendons and whatnot, which leads me to the tendon sheaths. That's what I was thinking of. All right, these tendon sheaths are basically going to wrap around the tendons and again help to reduce friction. So we'll see it in areas where there's quite a bit of motion and movement that occur. We'll also have our fat pads. You'll see those quite a bit in joints, and sometimes on an X-ray, the fat pad can fool some people sometimes, and people will think of it as swelling or inflammation in the area there. All right, but again, one of our functions of fat is protection, cushioning, insulation. Well, in this case, it is going to act as cushioning. So here's a nice picture of some of our tendon sheaths here. Okay, you can see it's this outer blue covering. All right, and then you can see right below here are the tendons. So you'll see they'll just wrap around the tendon there, and they'll help to protect the tendon, reduce friction. Okay, I would love to continue on, but this is a good place to stop. All right, we'll talk about the classification of our synovial joints next week. So let's take a break here for a few moments, about 20-minute break, and then we'll come on back.